Good afternoon, everyone. Would you take your seats? Thank you. Welcome to the May Food for Thought seminar. I'd like to acknowledge the traditional owners of the land on which we meet today, the Whadjuk Noongar people of a proud Noongar nation, and recognise their ongoing connection to the land and their contributions to the life of our city and state. And I pay my respects to elders past, present and emerging, and extend that respect to any Aboriginal and Torres Strait Islander peoples here today. Before we move on to today's presentation, I'd just like to share a couple of updates from the Foundation like I do every time. You may have noticed that work has actually commenced on our courtyard. We've fenced it off and the equipment's in place, and you're going to see the activity ramping up day to day now, so that's really exciting for us. Weather permitting, of course, we remain on track to have completed the courtyard and external works capital project early in the new financial year. And as I've said before, inevitably there may be some disruption, but we will work with you to minimise that so that it doesn't impact your day-to-day work. It's now my pleasure to introduce today's speaker, Professor Girish Dwivedi. Professor Dwivedi is the inaugural Wesfarmers Chair in Cardiology at the University of Western Australia, Harry Perkins Institute of Medical Research, and consultant cardiologist at Fiona Stanley Hospital. Prior to taking up these positions, he was appointed as a clinician scientist and consultant cardiologist at the University of Ottawa Heart Institute in Canada. His background and training to date is unique, and he is one of a few cardiologists in Australia who have advanced level 3 multimodality imaging training. Professor Dwivedi has published over 300 manuscripts, including several in top-tier journals such as Nature, Annals of Internal Medicine, and the Journal of the American College of Cardiology, demonstrating a high level of research intensity and productivity. I'd also like to thank in advance Professor Trevor Murray, who once again will assist us by facilitating the Q&A session and officially close the event. But now please join me in welcoming Professor Girish Dwivedi and his presentation on inflammation. Is it really the silent culprit, the new smoking and cholesterol? Thank you.
Thank you, Anne. Very good afternoon, everyone. It has taken me 6 years to come here. I arrived in 2018. I think Gerald was one of the first person I met, along with Trevor. Always wanted to come, but it's taken me, and probably the fault is mine. These are my disclosure slides. None of these are probably relevant for today's talk. This pertains to my work with a lot of work I do with CT and artificial intelligence. I thought I will start with this very provocative paper, which was published only last year, actually late last year. I don't know, Gerald, did you see this paper? Yeah. This I thought was a very provocative paper, and before we had GLP-1 agonists, ketogenic diet was one of the facts. In fact, I have seen people losing a lot of weight. But if you look very closely, especially there's an entity called LMHR, that stands for lean mass hyperresponders. So they lose a lot of weight, but their LDL cholesterol goes up. Triglycerides goes down, LDL cholesterol goes up, and this paper has almost everyone. So Khurram Nasir is one of the biggest names when it comes to CT and Agatston score, calcium score. All the power of zero comes from his lab. Matthew Budoff is again a leader in CT world. What they showed in this paper, they had a head-to-head comparison with Miami Heart Study, which was again, and it was a propensity-based matching. What they showed that people who were on ketogenic diet, which is a CRD, carbohydrate restricted diet for 5 years, the plaque between the Miami Heart and ketogenic diet, the plaque on CT scan. They're a very strange way of using, estimating the plaque, which the method they used was a total plaque score. They did not go for more finer details, which actually they subsequently did in the second paper, but the plaque in the two groups were not dissimilar, very similar. And you can see, as expected, the LDL cholesterol level in the ketone group was significantly higher. This is 272. I did the math this morning. This is coming to 5.2 LDL cholesterol, so it's fairly high. And triglycerides are near normal. I promptly sent the paper to one of my close colleagues, Dr. Nick Lan. He is lecturing somewhere in Melbourne, and he sent me a list of trolls, who were commenting on the paper, saying this study has not been properly done. And there were some very unprintable things I saw on LinkedIn in response to this paper. But earlier this year, this was the second paper from the same group. What they did this time, they did something even more unique. They had the CT scan, and then a year after, they repeated the CT scan in the same population. So previous paper was 4.7 years. The comparison 4 years of ketotic diet. This was 1 year. CT scans were done at the interval of 12 months. What they showed, again, something very interesting, the LDL cholesterol level, but they also looked for ApoB. Those who do lipid clinics will realize that one of the criticism of the previous paper was that when you take a ketogenic diet, the type of cholesterol you get is a more higher weight or a buoyant cholesterol versus more atherogenic cholesterol variant, which is the smaller variant, and also ApoB takes into account the number of particles, lipid particles, versus just the LDL cholesterol. What they showed that ApoB had no predictive power as far as plaque progression was concerned. More importantly, other plaque metrics, which is baseline calcium score, and they also did a TPS that predicted the plaque progression. I thought these papers were pretty. They were controversial. That's why they didn't go in JAC. They went in JAC Advances, where you have to pay $3,000. But they were pretty interesting paper to my mind. I mean, the question I asked was, is there things other than LDL cholesterol which is driving atherosclerosis? Gemma Fictree has done a lot of work on what she calls SMURFless, which stands for lack of standard modifying risk factors. So standard risk factors are things like diabetes, hypertension, and her work is that at least in not only in Australia, but in very developed countries, we are seeing patients who do not have these risk factors, but they still present with myocardial infarction. In fact, they seem to do as bad or probably worse as compared to patients with risk factors. Again, this got me to think, I mean, I've been thinking for the last 7-8 years, is there something other than LDL cholesterol which is driving this problem? This was the paper when I was finishing my training in UK and just was about to go to Canada for training in PET-CT. And this was a fairly interesting paper, rosuvastatin to prevent vascular events. Things for you to note is that almost all of these patients, 17,802, they had normal LDL cholesterol. They were treated with rosuvastatin, but they did have high sensitivity CRP, more than 2 milligram per liter, and that led to reduction in events. We are also familiar with this paper, CANTOS, which was a very nicely done trial. We contributed to this trial when I was in Canada. Interestingly, while CANTOS, which used canakinumab, which is interleukin 1B inhibitor, that led to reduction in acute adverse cardiac events, but more people died of infection. So two things, they balanced each other, and ultimately there was no effect on mortality. And this is probably the last paper before I start my real presentation. This really caught my attention. 2012, I remember I was finishing my PET training in Ottawa, and this was a very interesting paper which was published in Nature. What Matthew Narendorf's group, and they're quite big name in Mount Sinai, known for CHIP and lots of other things, and lots of data how inflammation drives atherosclerosis comes from Matthias's group. They tied the LAD of ApoE knockout mice, and what they showed that in the group where they had tied the LAD, means caused the myocardial infarction, that led to plaques which appeared unstable. When I say unstable, they had more monocytes, they had more macrophages. And where were these monocytes coming from? These monocytes were coming from spleen under the effect of, bone marrow under the effect of sympathetic nervous system. They were seeding in the spleen, and that led to more active inflammation. This sort of leads to the modality I feel comfortable with. So that's a MRI scanner, that's a PET scanner. The PET scanner has two bores. That's a CT scanner, and these ultrasound scanners. I feel all of them, they do complementary imaging, and they have their role to play in assessment of atherosclerosis or its complication. For the sake of today's talk, I'm just going to concentrate on PET and to some extent CT. So this is a FDG PET scan of a patient who has got vasculitis. So vasculitis essentially means inflammation of the large, medium-sized vessels. And this is a patient with atherosclerosis here who had a coronary artery disease. You will find that he has amputation on the left side, his left lower limb. Is what I really want to show that when you inject an FDG PET, so FDG PET is an isotope which is commonly used for cancer imaging. It goes and is taken up by the cells which are very actively replicating, or very active metabolically. If you're dealing with a cancer cell, you will see an uptake of FDG PET. But in inflammation, because inflammation, my talk is going to be based on inflammation, drives atherosclerosis. What is inflammation? Accumulation of polymorphonuclear leukocytes and macrophages. These are very active cells. They will take the FDG PET, and when you put these patients under the scanner, you will see inflammation in their arteries. The point of showing these two images was that active vasculitis or vascular inflammation and atherosclerosis, the picture on the FDG PET scan are very, very similar. I've covered a bit of this already. FDG activity in arterial wall reflects inflammation in atherosclerotic plaques. We normally go for a larger arteries like aorta or carotid arteries. The coronary arteries are a little bit small. Typical spatial resolution of PET, at least the PET we have got here, Sydney has got a better variant, is we cannot really scan, we cannot really quantify the inflammation in the coronary arteries. Is the PET here, we have to use aorta or the carotid arteries as a surrogate. There's a position paper. It's a very, very, very complex and time-taking to really do the estimations. We have now got artificial intelligence that does a little bit of help. Typically, you give it to the residents you don't love most. It can take up to 6 hours. But the good news is n is equal to 20 or 30. This is such a sensitive technique. Once you master it, n is equal to 20 or 30, you can get paper in circulation and JAK. So this is a fairly standard technique. We have got some expertise now at Fiona Stanley Hospital. We have written AI code, so a lot of this job is done by the computer. Now, I mentioned inflammation. I think drives atherosclerosis, accelerates atherosclerosis, but this concept is not new. In fact, a lot of the inflammation and atherosclerosis and treatment was started by Mark Nydorf and Professor Peter Thompson. And people have shown that if you treat inflammation with agents like colchicine, which is a weak anti-inflammatory agent, you can reduce the risk of adverse events. This is a data. One of the models I initially chose was pneumonia, because increasingly I was seeing as a junior cardiology registrar that patients with pneumonia, especially the elderly patients, when they were admitted in the ward, troponin had come and they would present with raised troponin, and we were called. And our first response was, this is probably related to everything else which is wrong with these patients, usually elderly typically. But what I increasingly realized that they were presenting with cardiac events. When I say cardiac events, things like heart failure or, for that matter, acute MI within 30 days. I also saw, living in Canada, there used to be lots of influenza outbreaks. After the outbreaks, our CCU would be full with patients who had influenza and then presented with heart attack subsequently. One of my colleague, again, Corrales Medina Vicente, he was an infectious disease doctor. He really focused on this and started publishing in JAMA and Circulation when that really caught my attention that we have to do something. I showed you a FDG PET scan previously. So this is an FDG PET scan of 3 other disease condition. I was looking for a human model. So whilst my interest was on basic science, but I was looking for a human model where I can test the hypothesis if inflammation drives atherosclerosis, or if we can treat inflammation by giving anti-inflammatory agents, and I can demonstrate reduction in atherosclerosis progression. So these were 4 human models. I sort of chose is I started with psoriasis and HIV at the time because these were more fundable as compared to SLE at the time. But before I embarked on my research program, and a lot of this is a combination of what I have done in this field in the last 7-8 years, is the first group I chose was patients with pneumonia, because that was constantly bothering me, is why these pneumonia patients presenting with either heart failure or acute coronary syndrome. And this was a fairly interesting study. What we did was we did 2 PET scans. And we typically chose patients who had only mild to moderate pneumonia and patients who were about to go home. So patient presented to hospital with pneumonia. They had hospital admission, so it was not community acquired pneumonia truly in the full sense. And just before they were about to go home, which means they had recovered from the pneumonia, I did a PET scan. So this was within 48 to 96 hours of admission. So that's an acute PET scan. When you do a PET scan, you're looking for FDG uptake in areas which are inflamed. I brought these patients back after 45 days. So this is after 45 days. So mind you, they were well enough here, and at this stage, they were out in the community, not suffering from any symptoms of pneumonia and doing their routine daily chores. I was expecting that on 30 days, I would actually see a complete, I would not see any FDG uptake. That's what you would expect. And if you listen to their chest or you do a fancy scans, even CT scan, you probably expect their chest infection would have cleared. What I found something which was quite interesting, and this is probably more interesting, 10% actually showed worsening in the inflammation. So from outside, they were perfectly fine. More importantly, 60%, even 45 days after the discharge, had persistent evidence of infection. And this was quite a significant finding because from outside, from CRP level, they appeared completely normal. And this was again the importance of corridor discussion. I was chatting with one of my cancer colleagues, nuclear medicine colleagues, and I said, how do you assess cancer activity? Do you have a measure to quantify the actual FDG uptake? And they used tumor glycolytic activity. So taking cue from that, and I spoke to my medical physicist, and we came with our own method of assessing some sort of objective evidence of inflammation. To put some numbers on it, we came with this total pulmonary glycolytic activity. All it indicates ongoing active inflammation in the lung. What you see here is quite interesting, is that of course acutely their infection was, their glycolytic activity was quite high. Normally you would expect complete, this bar chart to be here 0. It was not 0. More importantly, as compared to controls, we also found controls in the community is from the standard, I think from the cancer surveillance patient, the control with community, they had more inflammation in the lung. We didn't stop there. Then we did the arterial inflammation assessment, which was in the aorta. As I said, you can't assess in the coronary artery, so you assess in the aorta, and aorta is a very, very good surrogate. You can also do in carotid artery as well. What you see here, that vascular inflammation in the aorta was high, but even at 30 to 45 days, the vascular inflammation was higher as compared to control. And this paper got accepted in JACC cardiovascular imaging a few years ago. Moving on, by this time, this was the study I did in Canada. I came to Australia in late 2017. I really wanted to test this hypothesis: is if infection in patients with or without underlying atherosclerosis, if that or accelerates the atherosclerotic process. And this animal study gave me the chance. I chose ApoE knockout mice. It took me 1 year to find the dose which would cause, so we were literally injecting strep pneumoniae, Tiger 4 stain in their nose, and it took me 1 year to sort out the dose. Otherwise you want the dose that will cause pneumonia but will not kill them. So it was quite tricky, but we got it there. I put these unfortunate mice under all sorts of fancy imaging. I wanted to demonstrate they actually have pneumonia. So I did PET imaging. I also did the MRI imaging. Used lots of different radioactive isotopes, from FDG PET scan to sodium fluoride to some somatostatin receptors. Came to a conclusion that FDG PET is still the best, and did gene expression studies, oil red O image staining, trichrome staining, and to come to a conclusion which is in subsequent slides. And ultimately, we also did some mass spectrometry at the Australian National Phenome Centre. And this is just to demonstrate that whatever we did, we were successful in causing pneumonia in these mice. You can see the evidence of infection here. Lung SUE was higher after the post-inoculation. And this shows that on oil red O staining, the mice which were infected with strep pneumoniae intranasally, they had more plaques in thoracic aorta, and subsequently I will also show you went on to do immunofluorescence imaging, again the macrophage plaque content as well as NLRP3 plaque contents were higher in mice which were infected with strep pneumoniae. Subsequently, there was evidence of lipid accumulation and plaque progression, again in the aortic root. And lastly, we did as I said, trichrome imaging to look at SMC and collagen content. They reflect, so less SMC, less collagen, essentially means more adverse aortic root modeling. So essentially what we demonstrated, if I were to sum up in one sentence, that mice, ApoE knockout mice which were infected with Tiger 4 strain, they showed evidence of more plaques, and the plaques which were present were more vulnerable, and also evidence of systemic inflammation, and lastly adverse aortic root remodeling, which is a feature seen with adverse. Now, there was a very interesting time. So those who do research with ApoE knockout mice, they will realize that human atherosclerosis is actually driven by LDL cholesterol, and mice is mainly chylomicron and triglycerides. And there's some other issues as well. These mice, they never have vulnerable plaque. And what I was proposing here, that by actually causing infection, I could make their plaque vulnerable. So it was quite an interesting finding. We had our share of to's and fro's from many different journals, and ultimately we managed to get it published a couple of years ago. But this gave me more food for thought, is that what I have demonstrated now is that if you have an underlying plaque and then you suffer or then you experience infection which drives the inflammation, and pneumonia is just one model. You can have other types of infection. Then these so-called stable plaques can potentially become unstable. And I really wanted to test this hypothesis. And I got this chance, access to this database Western Australian coronary artery revascularization procedure. You can see some familiar names: Grant Waterer, Adil Rajwani and we planned this study. So essentially we started with more than 17,000 patients, and all of them had undergone PCI or CABG, which means they had previously coronary artery disease, and coronary artery disease sufficient or severe enough which required PCI or CABG, and they had also undergone intervention in one of the 7 WA hospitals. To cut a very long story short, we started with 17,000, and because of the various exclusion criteria, and one of the exclusion criteria I specifically wanted to exclude patients with less than 45 years. The reason I wanted to exclude these patients is, and I can have a discussion later on, is you want to select patients who are more likely to experience cardiac events. We ended up with more than 14,000 patients. And as I said, the idea was that if you have pre-existing coronary artery disease, and then you experience pneumonia, your chances of experiencing adverse cardiac events will go dramatically high. And we looked for the standard complications. MACE-1 included composite endpoint of infarction, stroke, PCI, all-cause death, MACE-2, and all MACE. These were the standard endpoints. I think I will just move on to the next slide. Yeah. So this is probably the money slide, is what you see here, and we had a fairly long, I think up to 13-year follow-up. Typically, we were told that if you experience pneumonia, you will probably, your risk of experiencing adverse cardiac event is highest within 30 days, and then it sort of decreases for a year, and then is pretty small. But what we were seeing, I mean, approximately very similar. The risk was pretty high within the first 30 days, and you can see the risk of the hazard ratio we got for myocardial infarction. Mind you, these were the myocardial infarction which required hospital admission, because this was based on the linkage data set we got access to 11 times. Slightly wide confidence interval, which was a big criticism, and I can address that later on. But general theme was that in this particular group, in very closely monitored patient and very, very robust and stringent criteria for definition, we found adverse cardiac event. More importantly, was the risk is present at 12 months. Even at the end of study, there was increased risk. We concluded pneumonia can lead to increased risk of cardiovascular complications. We also concluded that we did not know the mechanism. This was more a population-based study, and this was important. The first 30 days are important, but it can persist up to 13 years. Now, this is something which again caught my attention, is the risk if you experience pneumonia, then if you have underlying things like diabetes and hypertension, is pneumonia, the hazard ratio was highest for pneumonia. So it becomes quite an important factor, and this is something we are not really addressing at present. This has become a basis of my grant application with some of the colleagues sitting in this room, is we want to treat these patients, but we still, as I said, we still don't know what's the best way of reducing the inflammation or treating these patients. Now, before I go here, I have concentrated on coronary artery disease, and my interest has been more acute coronary syndrome. Dr. Rajwani is in the room. We have got a parallel study where we are to look for other causes, for example, any association or any fibrosis in the myocardium. So he has very elegantly published in last few years things like late gadolinium uptake or myocardial fibrosis post pneumonia. So that's another mechanism. COVID also gave me the opportunity to test this hypothesis again. As you know, a lot of COVID patients, they were experiencing heart attacks and other stroke and other cardiovascular adverse events. And I thought this would be very opportunistic to do a similar study, which I did with pneumonia, and the underlying hypothesis was again same, is that if you suffer from COVID, once you have recovered from COVID, you will have ongoing active inflammation in the lung and the vascular inflammation, and that would demonstrate, that would probably be one of the mechanism for adverse events we see in COVID patients. But I underestimated the problem I would face in Western Australia. Imagine this study we were doing soon after the COVID outbreak, and it was impossible to convince the technologists to have these patients under the scanner, because we did not know, we will have the medication. So it was quite a challenging study to do. But we ended up actually recruiting 60 patients. In the end, it took us 2 years. So these were mild to moderate COVID. So none of these patients had required ventilator. None of these patients were admitted for a prolonged time. Even if they came to a hospital for checkup, they stayed for a very, very short duration. They were done after 30 days, because that's the deal I stuck with the technologists. They said unless they are perfectly fine for 30 days, I'm not going to be anywhere near to them. We did a FDG PET scan, and as I said, I often use these surrogates for looking at coronary inflammation. This is quite important. When I was showing the Matthias Narendorf study, I mentioned these monocytes, these polymorphonuclear leukocytes. They actually, under the sympathetic stimulation, the progenitor cells are released from bone marrow, and then they seed in spleen. FDG PET also gives you an opportunity to look at bone marrow and splenic activity, which will be evident later on in some of my other studies. Not surprisingly, we demonstrated increased arterial inflammation in the descending thoracic aorta. So this is a FDG, what we call fused image, and this bright thing here is actually demonstrating inflammation in the aorta, which also you can quantify here, and you can see it was higher. High risk CVD patients are Gerald. These are the elevated lipoprotein little a patients, which we got them as a control. So they did not have pneumonia, but as you know, lipoprotein little a also is associated with increased risk of coronary artery disease. What you see here is that even higher than patients with lipoprotein little a here. We also showed correlation between vascular uptake and bone and splenic uptake. We concluded that on FDG PET scan, pneumonia patients, even 30 days after the COVID pneumonia patients, even 30 days after their infection has settled, they have ongoing active inflammation in the artery. We didn't want to stop there. We wanted to test their lungs as well. And it has taken us 2 years to come with all these ideas, ongoing signs of inflammation on these fused images. So this is a pure FDG PET. When I say fused means CT plus FDG PET. This is just a PET scan, and you can test your eyesight. If you don't see this black, then you have to visit the optometrist. But this suggests that there is ongoing arterial inflammation, and these are the numbers. So you can see here is there was more inflammation in the COVID-19 patients compared to controls. Again, we use the controls, the patients with elevated lipoprotein little a, and you would not expect them to have any pulmonary inflammation. More interestingly, the numbers here in bold means correlation, and you can see lung inflammation correlated nicely with their arterial inflammation. Essentially, I'm trying to suggest that these have ongoing active arterial inflammation, which could be the driver for accelerated atherosclerosis we see in these patients with COVID. I had a rheumatology colleague. He very kindly gave me this slide, and cardio-oncology was a branch which was a new branch in the US 10 years ago, and all the jobs are now coming in cardiac oncology, and apparently cardiac rheumatology has a similar sort of future. And the reason is we were taught as a young medical student is the rheumatoid arthritis, which leads to early and more severe variant of atherosclerosis. Especially, I remember seeing lots of young females presenting with left main stenosis with rheumatoid arthritis. But when you dig deeper, you will realize that it covers almost everything which you are taught in rheumatology. In fact, some of these conditions, for example, psoriatic arthritis, has a much higher risk. Very understudied disease is SLE for coronary artery disease. Not only they have arteritis, they have inflammation, but they also have lots of other things which makes them prone to have more thromboembolism as well. So that's like a double whammy. Is again, if you have a fancy imaging techniques which Sydney has got, University of Sydney has got, you can actually image the coronary artery and demonstrate ongoing inflammation in the coronary artery. Now, taking this into mind, I devised this time-wise. Taking this into mind, I devised this study. Again, this was the last study towards the end of my stay in Canada. I actually chose psoriatic arthritis patients. The reason I chose psoriatic arthritis patient is because I looked at the literature, and if you look at the literature, the risk of having coronary artery disease or association is even higher than diabetes, and I'm talking about 1.7 versus 2.1. Most of these psoriatic arthritis patients are actually, their BMI is on the wrong side of 35, they're obese, they often have a metabolic syndrome, and many of them have a pre-diabetic condition, versus rheumatoid arthritis who are typically actually thin. So that really got me interested. Now, during that time, we had some very potent anti-inflammatory therapy, anti-TNF alpha therapy came. So I devised this I thought was a pretty novel way of This was a prospective trial, CIHR funded. So I chose the psoriatic arthritis patients who required anti-TNF alpha therapy. So these were the highest risk patients who require very potent anti-inflammatory agents. And then you use some other non-anti-TNF therapy as well for psoriasis, like skin cream and PUVA therapy and others. And the third group, I was convinced by the reviewer to choose a control group called non-inflammatory conditions, and soon I realized that there's nothing like non-inflammatory which exists. Anyway, I ended up doing a FDG PET scan, but this time I also did a rubidium PET imaging. Unfortunately, we don't have rubidium PET imaging in Australia as of now. This is one of the best tests to look at what we call myocardial blood flow reserve. And that's myocardial blood flow reserve. Essentially, as the name indicates, it looks at the microvascular. It really interrogates the microcirculation of the heart. The idea was that I would do a FDG PET scan to look at arterial inflammation. I would then do a rubidium PET scan to look at MBFR or myocardial blood flow reserve. I will then bring these high-risk patients 6 months after the treatment and see if I can demonstrate reduction in the arterial inflammation and also reduction in improvement in the MBFR. Results were very, very similar, again, along the lines which I was expecting. You can see here, they should look more gold, they should look less. So this is the group where we treated. This shows that there was ongoing arterial inflammation, and this is reduced. Of course, in the group which was not treated, there was no change, and in the control group, there was no change. More importantly, what I could demonstrate, and that got this paper in Journal of Nuclear Cardiology, that in people who responded to treatment, which means anti-TNF therapy in patients with psoriatic arthritis, where they felt better and their joints became better, their inflammatory markers came down, in that particular group, it led to improvement in myocardial blood flow reserve. So now what I'm saying is, by giving this anti-systemic treatments, I'm actually benefiting their heart, and that opens a Pandora's box. It didn't stop there. I also persuaded my HIV colleagues to send their HIV patients, put them under a PET scanner again, FDG PET scan. This time, instead of anti-TNF therapy, I actually treated them with statin, rosuvastatin. The study got bounced by a $20 million grant from NIH, and I just could not compete with $300,000 in my pocket. But is what I was able to show here this time is just not the artery, but I could also, as I said, PET allows us to really interrogate their spleen and also the bone marrow. And I could show that with statin treatment, and statin has a pleiotropic effect. It just does not bring the cholesterol down, but also does lots of other good things. So it led to reduction in inflammation and also bone marrow as well as splenic uptake. I said lots of good things about FDG PET. I think the only thing good about FDG PET is because we have got lots of experience from a heart perspective. From a cancer imaging, it's a fantastic tool. From a heart perspective, we've got lots of imaging. We have got access to FDG PET, although there's a long waiting list, and we feel comfortable looking at the images. But there are some very new agents which are coming up, especially somatostatin receptor blockers, and sodium fluoride. And as we gain more experience, I see, especially for the heart, FDG PET may not be the agent of choice in the next 5 to 10 years. Met my gastro colleague and persuaded one of the star ATs, actually Gavin Huangfu, with David Thomas, who is going to be applying for cardiology. They spent their last 2 years looking at inflammatory bowel diseases and the effect of treatment. So which inflammatory bowel diseases? Again, very similar to psoriasis, or for that matter, rheumatoid arthritis. People with ulcerative colitis, people with Crohn's disease, they also have a higher risk of, or there is association with coronary artery disease. So there were lots of small studies, but look at these numbers. So these two boys essentially looked at all the studies, and 6,153 studies. Took them 2 years, more than 2 million individuals. 240,000 patients with IBD. Again, they demonstrated increased hazard ratio of adverse events, myocardial infarction, and stroke. What was interesting, and this is one question I really wanted to answer, was there were a few reports which suggested is that Janus kinase inhibitors it caused few thromboembolism, and there were few case reports suggestive of even myocardial infarction. When we combined all the data, we didn't find anything sinister about Janus kinase inhibitors. And that's why this paper got accepted only last week in Journal of Crohn's and Colitis. I can't finish anything without bringing Nick Lan into my discussion. So he is one of my star colleague and also a PhD student. So he is researching patients on diabetic-related foot ulcer. So they have a diabetes, but they also have an active foot ulcer. Again, the underlying theme is this ongoing infection. When you have an ongoing infection, that is going to cause infection. And often they have quite a deep infection extending up to the tendon, muscle, or even bone. What you see here, that if the infection is deep, and they're also infected, so this is D++, I+, versus D-, non-deep infection, no infection, you can see the risk of MACE was 27% versus 7.9%. Again, same underlying theme. If you have deep infection, more inflammation, or active inflammation, then these patients, they're more likely to suffer adverse event. Increasingly, I'm getting interested in hepatic steatosis and inflammation, for that matter, seems to be center. It's called, one of my colleague Koya calls it metaverse, is inflammation is center of everything else. And the reason is probably will be obvious in the next slide, is because this is the second tool which I use, is a cardiac CT. Not only you can image the coronary arteries, but when we do a cardiac CT, we get a little bit of liver, and that comes free for us. We used that opportunity and persuaded Gerald and Jing to share their familial hypercholesterolemia database. And as you know, many of these patients had undergone CCTA scan. Gavin very kindly did the analysis. So when you do a CT scan, not only you can pinpoint the sites and the severity of stenosis or narrowing in the arteries, but you can do some other fancy tests as well, what we call high-risk plaque, and these are their standard definition. But you can also do what we call PCAT or FAI, or fat attenuation index, and that's a marker for inflammation around the coronary arteries. Once we had all this information, we realized that we can actually, the slices of liver, and if we also get a slice of spleen, we can find a way to estimate their hepatic steatosis, or that means fats in the liver. Fat deposition in the liver, as you know, is quite common in patients with diabetes or metabolic syndrome. And to me, the results were interesting but not unexpected. What we could demonstrate, that people who had more hepatic steatosis is they had more severe stenosis, coronary stenosis, but they also had more high-risk plaque. We didn't stop there. We thought we should do a meta-analysis of all the patients, all the data which around Sarah Sugdam did it and just got published late last year. Again, showing hepatic steatosis patients, they are just, you can identify by, they identified themselves, especially the ones with severe steatosis, as they may have some underlying severe heart disease. Forgetting the name is of the German doctor who won the Nobel Prize for discovering the structure of benzene in dream. I thought I could come up with a classification and which that would be used every time when you classify, because inflammation is the central theme, but inflammation can come from various different sources. How I'm doing time-wise? I still have 15 minutes or 5 minutes. So I came with this idea more and more I see, more and more I realize that last week someone published a paper that people who live in the vicinity of Heathrow, where lots of planes they fly because of the noise pollution, and this got published in JACC, they have higher incidence of coronary artery disease. So it's the inflammation which is driving, and I thought this was fairly neat idea, is unfortunately only HLC accepted. Once I became a sub-editor and I had done their 20 reviews, is got bounced from every journal. I've said lots of good things about inflammation and if you treat the inflammation, but I think it's important that I give a balanced view. There are lots of trials which have shown that treating inflammation just randomly may not lead to reduction in atherosclerosis progression. Methotrexate was a one important trial. CIRT, NIH spent a lot of money, and that did not show reduction in adverse events. Similarly, lipoprotein associated PL2, daraplatinib, and vareplatinib also did not show any reduction in cardiovascular events. And this is probably the most, again, sort of semi-controversial trial, which was only published in the New England Journal of Medicine, I think a month ago. What they did was they treated acute coronary syndrome patient, acute myocardial infarction patients very acutely. So within, I think, 48 hours, they treated with colchicine, and they did not see, I repeat, they did not see any reduction in adverse events. And I can debate with people later on what caused this, but if you read the editorial, the two things which come out, this trial was done whilst the COVID was still active. So that's given as one of the reasons. And secondly, a lot of people suggest that maybe colchicine was started too early. Is when you start colchicine too early, it increases the risk of atheroembolism, and that's what people think, that you have to pick the time. And this sort of sets the scene for my summary and future direction. So I think hopefully people sitting in this room will agree that there is a causal role for inflammation in high-risk atherosclerosis. Our treatment paradigm is now based on lesion anatomy and extent of myocardial ischemia. I feel time has come for this to change. But as I said, there are negative trials. This translation will not be easy, and there will be challenges. The right patient, the right time, the right probe, the right target, the right dose, that still needs to be defined. Now, as I said, people have not given up. So we started with the IL-1B inhibitors, but we are now moving more towards IL-6 inhibitors. And Novo is spending billions and billions of dollars on this. And you can see from these studies, there is enough genetic data, there is enough clinical evidence to suggest that maybe if you go a little downstream and you hit a little downstream in the inflammatory cascade, you might reap the benefit. I would like to end by showing these are the ongoing trials. So the interest is, there's immense interest in this field, lots of money that is being pumped mainly by the pharma industries, and all these trials will come out in next 2 to 3 years, and I think that will shed more light on how this field evolves. Sorry, I have lost my thank you slide, but I can get it, hopefully. That's important for I don't know what happened. Anyway, that's okay. That's all. Thank you very much. Thank you slide.
Thanks, Girish, for taking us through a whole tour there of your work and work of others in the area. It's very interesting. I guess we've heard a lot about, or some information about long COVID. Have you had, your patients, your COVID patients were only, was it 30 days, greater than 30 days?
So 30 days, so it won't be a long COVID, it will be like intermediate COVID. Right. There's lots of grants. Trevor, frankly speaking, I lost interest in COVID, but it was very difficult to get any money. It was very difficult to get any publication. And then I thought, yes, COVID is different, but how this is different than any other infection I'm chasing, for that matter, pneumonia. So I've left it. There are lots of grants on long COVID, MRFF, but yeah. Thanks. I just wanted to show I started with this. A lot of cardiology residents are missing, and 95% of the work which I have presented actually has been done by my residents. So I'm immensely grateful. I have probably got one of the best teams, Trevor would confirm, in cardiology at least, working with them. So I thank you to all of them. Yeah, sorry, it's a long COVID, so no, it was intermediate COVID. But there are other people who are doing, of course, they are doing markers, systemic inflammatory markers. Jeremy is collecting samples for phenomics. There are MRI studies. People are even doing flow MRIs to look for cognitive dysfunction. But I'm not doing any study. It's extremely difficult to do FDG PET scan these days in Perth because of there are cancer patients waiting.
I mean, I guess potentially you could do other things with the COVID. I mean, is it over 75? Are those over 75 or thereabouts? They're the antiviral agents that act quite efficiently in terms of COVID. I mean, would that be an interesting group to look at in this setting?
So one of the studies, I think it's Graham here. No, Graham. One of the studies which was not in COVID, but we wanted to do in influenza for that matter, is we wanted to do a CT scan at the time and then repeat 3 months later. We also wanted to have a control arm where people were given influenza vaccination. Lots of challenges is particularly with COVID, because as you know, COVID vaccination also causes myocarditis. So it comes to hit us. Even for our paper is the inflammation which you are seeing is because everyone in Australia got vaccinated, or majority got vaccinated. The inflammation you are seeing is how can you be so sure that this is COVID is and not vaccination related. Is those things can be done. Of course, we can do arterial stiffness studies, flow-mediated vasodilatation, and even simple things, carotid ultrasound to look for. Yeah.
Are there any questions, Gerald? I think you need to talk into this.
Yeah, thanks very much. Really quite a tour de force. Can I ask you a simple question, just to get your opinion, on simple markers, biomarkers of inflammation? On the one hand, there's CRP that, Paul Ridker, who's doing all those trials, and, he's got the patent on the assay. Is it useful? And also a lot of papers coming out from lots of centres now saying that the white cell count, just a simple leukocyte count, is a predictor that overrides anything. What's your take on these biomarkers? Are they useful, or are they, as it were, imagined markers, really?
So Gerald, your questions are never simple. So I'll start by saying, if I truly believed that we had high sensitivity CRP, which is quite easy to order and get, I would not have gone on the FDG PET route. So answer is high sensitivity CRP is probably not the biomarker we are looking for. And the reason is very simple. It reflects active systemic inflammation, and what I'm interested is active arterial inflammation. It also, one of the commonest thing which affects high sensitivity CRP is smoking. If you smoke and then you repeat the high sensitivity CRP, the values can, and we are dealing, as you know, Gerald, is only 2 milligram. So that's the cutoff. So very small change drives the atherosclerosis. There are 3 or 4 other biomarkers which I have seen in the literature. One of them is myeloperoxidase. There's a lot of work going in Sydney. Phospholipase A2, that's the daraplatinib trial. And as you said, total leukocyte count. I don't think total leukocyte count is probably the answer. There is a lot of interesting data coming with myeloperoxidase. We're still looking for active biomarker. The other joker in the pack is CT-derived inflammation around the coronary arteries. I mentioned PCAT or fat attenuation index. So we have that information, quite easy, and a non-invasive test. I'm afraid I don't have the answer what's the best biomarker for all its practical purpose. I do know that high sensitivity CRP is not the answer. We are still looking for a better measure.
So myeloperoxidase is actually intimately involved with oxidative stress. Is that thought to be one of the sort of...
ultimately, how LDL, or for that matter, diesel fumes, or everything seems to affect the oxidative stress in the end. Where that stress is coming from, and if that's causing endothelial denudation or damage to the intima, that will lead to acceleration of atherosclerosis.
Hi, I really was fascinated by your work in how pneumonia can be an independent risk factor for the acceleration of coronary artery disease and like sepsis broadly. So my question is, in the clinical world, when people come in with like a trop leak in the context of sepsis, often put down to a type 2 MI, how do you think that will now change going forward and the need for potential angios for these patients?
So it is a great question. I wish I had an answer. In fact, me and Trevor and Gerald, we are putting a $2 million grant to answer the exact question you've asked. So when you get infection, is a fairly fulminant or aggressive infection. Now, if that leads to troponin leak, there could be two causes. One is it could be because of the myocardial insult. So you can have myocarditis, or you can have, and especially there are some animal studies which have shown seeding of a type of pneumococcus in the myocardium. Dr. Rajwani has done some work in patients with pneumonia. He's brought them back for an MRI scan, and he's shown that these patients have evidence of fibrosis or late gadolinium enhancement. So that's the myocardial pathway. I will answer the second part of the question. What I'm interested that especially, and that's why I said I chose patients who were more than 45-year-old, is because I wanted them to have some plaque. If they have some plaque, and suddenly their coronary arteries, or for that matter their systemic circulation, is bathed by all these cytokines and other inflammatory mediators, that plaque is likely to become more unstable. Is the challenge we as a cardiologist face is what causes myocardial infarction is not the degree of narrowing, is a plaque rupture. And the most common plaque which ruptures is usually a sub-occlusive, or is a less than 50%. So if you were to do a coronary angiogram, is you may not see occlusive coronary artery disease unless you do intravascular ultrasound. So or you do a test, which I do, is a cardiac CT scan. You're asking a more practical question, is that if they come with a severely elevated troponin, is which patient you would send them for coronary angiogram. That's a clinical decision. Is the decision is based on if I see wall motion abnormality or heart failure, or dramatic increase in troponin, 1,000, 2,000, 3,000. So that's the group I send. Often I actually do a CTCA scan just to get an idea what sort of coronary anatomy is dealing. A bigger issue is how do you treat? Should you start these patients with Professor Grant Water starts them on aspirin at Royal Perth Hospital? Is that the way forward? The trial we want to do is we want to start them on EPA, is omega-3 fatty acids. We think that would reduce the inflammation. So we still don't know the answer, is whether you would start them on statin. Probably yes. Yeah.
One quick question, because I'm mindful of the time.
Yeah, so it's a technical question about CT coronary angiography, and it relates to the use of photon counting CT that's been really quite popularised. There's one centre in WA. Can we just have your opinion as to what its benefits are, or is it, as it were, in the imagination that it's useful, really?
Gerald, it's a difference between a Toyota car and a Porsche car. If the normal dual source CT will also take you from point A to point B. Now, with photon counting CT, let me start with the advantages. It's much better to start with the disadvantages. It's a $4 million machine. I have been trying to get that machine at Fiona Stanley Hospital for the last 3 years. I have not succeeded. It's not super expensive in a sense that a normal dual source CT is around $2 million. So it's not too big, meaning tenfold, but still DOH doesn't see that as a good investment. With photon counting CT, the biggest advantage is especially when it comes to plaque characterization, is when you are looking at high risk plaque, it's just a completely different beast. Also, I am particularly interested in myocardial characterization, and that's one big thing, what we call almost like histology level imaging with MRI. Photon counting CT allows you. But when it comes to stenosis detection, is if you have brought the heart rate down and you have a good enough scanner, which you have bought after 2015, they will answer the clinical question. But if you're looking for a research thing, whether I would like to have an access to technology that, yeah, of course, yes. Clinically, photon counting CT, probably little less reduction is, the pictures are pristine. But I've been telling a lot of my junior colleagues that, don't train yourself in photon counting CT because they are very easy to report. Start reporting in scanner we have at Royal Perfect or at Fiona Stanley Hospital. You will become much better doctor, then move on to photon counting. I personally see all CTs, cardiac CTs in this country in next 10 years will be a photon counting CT. But that's where the technology is moving, and it's not $20 million investment. It's only $4 million. I think cost will come down.
I know we're running late, but we've got a question that was submitted online about the role, your comments about the role of genetics, and I'll add epigenetics. Quick answer if I can.
Look, we were chatting this just before I came, is genetics plays a role. There's absolutely no doubt about it. I see atherosclerosis as end result of multiple insults. Genetic makes you prone, and if you have a disease like familial hypercholesterolemia, for that matter, homozygous, you're bound to develop coronary artery disease at some stage. But it's just not one thing which drives atherosclerosis. It's a combination of multiple factors, and that's where inflammation comes from. That this is one of the important mechanism. And perhaps people who are
epigenetics, which takes into account environmental, lifestyle factors.
That was of course, people have done studies in monozygotic twins. If you are a couch potato and a smoker, you get hit by COVID, you can have the same genes and same everything else, but the other brother or other sister is much more likely to experience the event. Epigenetics has a huge role to play. More importantly, we can't change our genetics, but we can change our epigenetics. So I think that's where the focus should be.
Yeah. Okay, look, I think we are going to have to stop. I'm sorry we are running late, but I think I can tell by the questions from the audience there's been an enormous interest in your presentation. We're going to have to ask Darren, we're going to have to ask Girish back for part 2 later on in the year. So please join me in thanking Girish for his presentation.
Thank you very much. Thanks very much.